probes. Just testing this one. The one that was on the stage. Is that working? That's better. There we go. That's that one.
Testing, testing. Hello. Had my sandwiches. Are you speaking? When you finish speaking. Good afternoon, everyone. I think we're pretty much ready to get going. Thank you very much for coming along today. I'm absolutely delighted to be here to conduct the NHS Shetland annual review and to welcome everyone, whether you're attending here in the building or whether you're viewing this session online. My name is Maree Todd, MSP, and I am the Minister for Drugs and Alcohol Policy, a junior health minister in the team, who also sport. With me from the Scottish Government is Caroline Lamb, who is the Director General of Health and Social Care and also the Chief Executive of NHS Scotland. NHS Shetland is represented by Gary Robinson, who will be well known to you all, up on the stage ready to do his presentation, and by the board, he's the board chair, and by Brian Chittick, the Chief Executive. So the annual review is an annual event, happens every year, and it is aimed at discussing how effectively the board has delivered local services in the preceding year and exploring key future developments and challenges. It's an important part of the process of holding boards to account for the very large sums of public money that that are invested in NHS Scotland. And I've spent this morning meeting local NHS staff and patients to get an idea of some of the issues affecting them. This session is structured around the board's performance and national and local priorities. The board chair will undertake a presentation on these. I'll then chair the Q&A session where questions are clearly for the board, and save all your really tricky questions for the board. I'll ask the chair and the chief executive to respond. I need to be clear at the outset that it is not appropriate to answer questions about individual patient-specific cases in this public forum, but they can be followed up by the board after the review. Given there's no ability for the people who are viewing the session online to ask a question in real time, the board's offered the opportunity to lodge a written question in advance, and I understand a number of advance questions have been received, and we'll put these to the board leadership before we open up to the floor here today. I'll also, after this, attend a private session with the board leadership following this meeting, and that session will include more detailed discussion about local performance, and the main points from the whole day's scrutiny will be summarised in a ministerial letter that will be issued in the coming weeks, and that will be published on the board's website. So, without further ado, I'm going to hand over to Gary for his presentation.
Thank you, Minister. Good afternoon, everyone, and thank you for joining us for NHS Shetland's annual review for 24-25. This year's review reflects not only our performance, but also the pressures and opportunities we face as a system. It's a chance to acknowledge the work of our teams, the resilience of our communities, and the importance of collaboration across sectors. It would be impossible in such a short time to mention the work of all our teams and services, but if you'd like to hear more, then please listen in to our regular NHS board and IJB meetings. It's important to highlight the context in which we're operating. The NHS was never meant to go it alone. For people to thrive, Shetland must work together across health, social care, education, housing and beyond, and especially as we have some shared challenges. Our population is changing, an ageing population that has more and more complex health and care needs. In the last 10 years, those aged 75 and over increased by 46% in Shetland, while in Scotland the increase was 23%. Illness and health are evolving, with more people living longer, with an increasing number of complex conditions. Our workforce is evolving too, and also ageing. We have more limited recruitment pools and changing needs and expectations in our workforce. And across the public sector, resources are stretched. A key objective for NHS Shetland is to become sustainable in the longer term. something we've been working towards for a number of years and is made much more challenging by those hotspots that I've just mentioned. Financially, we've delivered a break-even position with a small underspend on core funding. We achieved 3.9 million in savings. 0.6 million of these are recurrent savings, such as delivering services in different ways. 3.3 million are what we call non-recurring, such as vacancies from unfilled posts that we still require. However, we still need to identify 6.9 million in recurring savings over the next 3 years to become sustainable and meet the Scottish Government's 3% savings target. This is a significant challenge, and it will require difficult decisions, innovation, and system-wide collaboration, but we're up for that challenge. On workforce, we've made progress. We continue to value our supportive wellbeing culture, promoting attendance to support people to be well at work, and this is reflected in our low absence rates compared to other boards. We've also continued to work on different ways to build sustainability in our workforce, now and in the future, including increasing our international workforce. 5 new international recruits joined us last year, taking our total to date up to 11, which is bringing real stability to the teams that they're working in. Offering opportunities to young people, 37 young people took part in work experience across the board, and we've put a lot of work into building our partnership with the Developing Young Workforce programme to showcase opportunities to young people across Shetland. We've also have a number of apprentices working and learning in roles across the organisation. We've 13 Open University nursing students currently training. This gives people the opportunity to work and study close to home, making a nursing qualification a viable option for people who can't go away to study. We also continue to be a strong and respected site for medical education, with placements across the year. Our staff stands at 896 people, or 695 whole-time equivalents, an increase of 37 from last year. I think it's also important to note there that we have reduced agency and locum use over the same period. Turnover in the organisation has reduced from over 15% to 11%, which is a positive sign of growing stability, and our sickness rate last year, the lowest in Scotland at 4.4%, well below the Scottish average of 6.4%, demonstrating our drive to engender a healthy and productive work environment where staff feel supported. On buildings and estates, we've begun an essential infrastructure work across our estate with substantial funding secured to keep our buildings safe for continued use for the next 10 to 15 years. And at the Gilbert Bain Hospital, service relocation plans are currently underway. The original building dates back to 1961, so it's among the oldest estate currently in use in the whole country. With support from the Endowment Fund, we've also added 3 new polycrubs, 2 in the Montfield grounds and 1 at Walls Health Centre to make better use of the land we own. 1 for staff use, 1 looked after by staff and a therapeutic space for patients, and 1 in partnership with Food for the Way, supporting well-being and therapeutic activities. Another key objective is to provide excellent services for people. We know that this is about more than just waiting lists, and we gather lots of information about how our services are performing day to day, providing what really matters to people. We can't cover every service today, but we'll highlight key areas. For more detail, I encourage you to attend our board meetings or IJB meetings, as I mentioned earlier. In planned care, performance is strong in many areas. 85% of patients waited less than 6 weeks for key diagnostic tests. This is a really important step in people getting the treatment that they need. Over 1,300 local MRIs have been completed to date, saving a lot of people from having to travel for essential tests. Cancer care met the 31-day target 100% of the time, though the 62-day target was met 66% of the time, below the Scotland average of 72%. Outpatient and inpatient wait-in times are better than the national average. 68% of inpatients' day cases were treated within 12 weeks. Scotland is 58%. 70% of outpatients treated within 12 weeks, and again that's ahead of Scotland, which is at 63%. However, challenges remain, particularly where the care pathways are shared with other boards. Our challenges in meeting waiting times targets is mostly due to managing the demand for visiting services, for example, ear, nose and throat, dermatology, orthopaedics. So the patients who are having to wait longer are from a small number of specialty areas. It is similar for patients waiting cancer treatment, where people can receive treatment locally, they will receive it within 62 days. Where patients need more complex diagnostic tests or treatment in a specialist centre, the waits are longer, as these specialties are struggling to meet demand in boards that provide those services for us. Our health centres continue to work hard to deliver high-quality, person-centred care. In the National Health and Care Experience Survey, 97% of people rated their community out-of-hours care positively or neutrally. 96% felt similarly about their health centre care, again above the national average of 88%. Medication reviews are on track. These are important to make sure people are getting the best from their medicines and not experiencing adverse effects if possible. More than 8 out of 10 patients with repeat prescriptions have had recent reviews, meaning that over 11,000 reviews have been completed. Long-term condition checks have improved significantly from 37% overdue to just 18% overdue, meaning that people's health is better looked after, helping to prevent complications and ill health related to their conditions. Unscheduled care is under pressure, particularly due to delays in discharge. 3,057 bed days were occupied by people delayed in hospital last year, more than double the previous year. 54 people were recorded as waiting more than 14 days at census points, up from 31. This is driven by limited social care capacity, both in terms of beds, appropriate accommodation and staffing in the community. Managing these delays and more complex discharges requires a lot of work between teams to get people safely home from hospital. On a positive note, our new hospital at home model, supported by Scottish Government funding, is showing promise. 50 patients are being supported and 497 days have been saved through this care. And capacity is set to double in the coming year. This service lets people who need hospital-level care for a short time receive that in their own home, and has been well received by patients, families and professionals so far. 88% of A&E patients were seen and treated within 4 hours. While this is not meeting the national target, it is above the national average, and we look closely at who has been delayed in A&E to understand patterns. Often these delays are so that people can be safely discharged home from the emergency department rather than having to be admitted to hospital. Mental health services continue to work hard to meet demand. CAMS saw all patients within the 18-week target with an average wait of under 8 weeks. Psychological therapy saw 262 new patients this year, and 6 out of 10 were seen within the 18-week target. Substance support and recovery service saw 92% of patients within their 3-week target and continue to progress towards the medication-assisted treatment standards. There are particular challenges here locally where we have significantly more people accessing services than other island boards, but are provided with less funding than other boards to support them. In neurodevelopmental pathways, demand is rising and we continue to have real challenges in meeting this demand. We know in Shetland we have double the national average of learning disabilities in neurodevelopmental diagnosis. I'll get that in a second time maybe. There has been a significant increase in referrals for children into neurodevelopmental pathways for assessment over recent years. We had over 200 children on waiting lists awaiting neurodevelopmental assessment for example, for autism or ADHD across our services at the end of 2024-25. Over 300 adults are currently awaiting ADHD assessment as well. We're currently targeting our limited resources to those most at risk and looking at different ways of offering support to people who are waiting and who have accessed services to support better outcomes for everyone. Our third core objective is to support the building blocks of health. Almost every aspect of their lives impacts on their health, so it is in our best interest as a healthcare provider to use our influence and expertise to create better places and spaces to support the health and well-being of our population. As well as providing day-to-day services, a lot of our teams work with others in organisations across Shetland and in other boards. Working together like this means we can move ahead bigger pieces of work to have a stronger impact and come up with a system-wide solution to shared problems like inequalities, the unfair, unavoidable and avoidable differences in health and social outcomes for people in our communities. Work to prevent ill health in the first place and give every child the best start in life. We do this through partnership work, for example, in the Shetland Partnership and Children's Partnership. We are a key partner in their local community planning partnership, the Shetland Partnership, leading on climate change and person-centred support projects and supporting compassionate Shetland and place-based approaches. We work to provide opportunities for people in Shetland throughout our work with the Employability Partnership and with the developing the young workforce and local schools, as well as looking at how we deliver services in small communities. For example, our islands with small populations are non-doctor islands to support and protect those communities. We also work to protect people's health, prevent ill health and detect disease at the earliest stages, for example by delivering national vaccine and screening programmes in a way that is fair, accessible and effective for people in Shetland. In closing, this review reflects a system that's under pressure, but also one that's adapting, innovating and collaborating. We've made progress in workforce stability, infrastructure investment and service performance, but we must continue to address the challenges in shared care pathways, mitigating limits of social care capacity and in improving adequate neurodevelopmental services, whilst maintaining a focus on their path to sustainability. I'd like to thank all our staff, partners and community members for your continued commitment to health and care in Shetland and for ensuring that we put NHS Shetland into the heart of our community and our community into the heart of NHS Shetland. Thank you.
Thanks very much for that, Gary. It's great to have that overview of all of the work that's going on in NHS Shetland, covering some of the significant progress that's been made as we've come out of a really tough period of time for health and social care services. But it's not like we're out of the woods yet. There's always new challenges to rise and face. And we had some insights into some of them from that presentation, so thanks very much. We'll move on now to the Q&A session. So we've got some written questions in advance. So as I understand it, the written questions were on a number of general themes, and they've been anonymised and summarised in 3 sections. So the first question asked the Health Board whether it's possible to have an MRI at the Gilbert Bain Hospital if medically necessary. I understand from this question the patient has heart failure and an MRI safe pacemaker, and would like to know if local facilities and staff are qualified and experienced to undertake such a scan. So I'll hand over to the board to respond to that.
Thank you. Yeah, I think Kathleen's going to take that question.
Thank you. Thank you for the question. Our MRI service is really new. It's been in operation for just over 12 months. There are around 8 to 10 patients who have pacemakers who would need this type of scan, and it isn't currently possible for us to be able to deliver that locally. The reason for that is that we need specialist radiographer and specialist clinical physiology input, and we currently receive that from NHS Grampian. So we do have an aspiration to be able to develop those skills locally, but that isn't something that we're going to be able to do quickly. We estimate it'll probably take a couple of years for us to be able to deliver those scans locally for those people who need them. So it is something on our development plan, but it's not something we're going to be able to do in the near future, and that's really because of the training requirements for staff in our team.
Thanks very much for that. The second question asks why prescriptions are limited to a month at a time, pointing out that health centres are often quite some distance away and public transport isn't ideal for collection. So again, I would like to ask the board to answer that question on the local position. Thanks.
Thanks, Minister. Our Director of Pharmacy, Tony McDavid, will take that question. Thank you.
Thanks for the question. It's a really important question. It's something we've been working on over this last year. If NHS Scotland looked at every single health board, NHS Shetland's only health board in Scotland, it's reduced the number of items provided to people over the last year, and it's because the team have been working at moving people from 28 days to 56-day prescriptions. So it's a really interesting metric, but it's one that shows that it's working. I think if anybody in the community doesn't have access to 28-day prescriptions, there are few circumstances that would mean that you cannot have longer than 28 days for certain prescription items, just to get in contact with their health centre, their pharmacy, or their dispensing practice wherever possible, or to bring it up at the next appointment that they're having many of the healthcare staff they're dealing with. They'll be able to go through any of the exceptions as well, but I'd really encourage the public and anyone who wants to have less visits to a pharmacy to do so.
Thanks very much. One after my own heart. So if you want 2 months supply largely, that is possible. Just chat to your prescriber, pharmacy, dispensing doctor about it. The third and final set of advanced questions are about the maintenance and potential longer-term replacement of the main acute hospital in Shetland. That's the Gilbert Bay. The questioners ask why local people are not getting a new replacement hospital, and whether it isn't a waste of money to spend millions to keep the current one going for another 15 years. So I know that there are specific considerations around the maintenance work required for the hospital, but before I hand over to the board team, I just want to say a few words about the national position on the availability of capital for infrastructure funding. The position's been extremely challenging over the last few years, and in early 2024, most new and prospective capital projects in the NHS were put on hold. That's reflecting pressures relating to ballooning construction and other costs, not least as a result of Brexit, alongside flat cash settlements from the UK government. That said, I understand that the significant investment in the essential maintenance works being planned for Gilbert Bay are intended to ensure that it remains safe, functional and fit for purpose for at least the next 15 years. But at this point, I'll hand over to the board for more detail on the local position.
Thank you, Minister. I'll say a bit on this and then I'll hand over to Kathleen. I think my first thought was just that. Could we move more quickly to a new hospital when we found out about the maintenance work that was required? But the timescale for the maintenance, it is fairly urgent maintenance, so that just wasn't an option, and we need to do the maintenance long before we could possibly get to the opening of a new hospital. So that really also adds to the situation that the Minister described. But I'll hand over to Kathleen for a more detailed response. Thank you.
Thank you. I suppose I have little to add to that, really. The original work that we did in 2019 to have a look at the overall condition of the hospital, which precipitated us developing or starting the process of developing a business case to replace the hospital, demonstrated that, as in Gary's presentation, we have an old building. It was built in 1961. We knew that it would need maintenance, and it does need maintenance, and that's something we should expect with an old building. But in the original piece of work that we were doing to develop the business case, we knew that it would be the earliest, if we had a new hospital, would be 2033. So I suppose it's an inevitable expectation that there will still need to be investment and ongoing investment in the hospital. And the position that we find ourselves in with the remedial work is really just that. So I don't think that the fact that we've spent money developing a business case in order to move forward has been poor value. That piece of work still has value, and we will pick it up in the future when we get the go-ahead to continue to move forward with that process.
Thanks very much. So I'm now going to open to questions from the floor. I'll just remind everyone again that it wouldn't be appropriate to answer questions about patient-specific issues in this public forum, but we can take those matters forward with the board separately. And with that, I will ask if anybody has any questions they'd like to ask.
Thank you. Thank you for the opportunity. It's both a national question and a board question. Learning disabilities annual reviews were really essential addition to preventative health issues. And I just wondered, given Gary's presentation of the situation in Shetland and the higher identification of people with learning disabilities, if nationally there's any leeway for increasing support for places where have a spike in that data, and also looking at, from the local board, just an update on how the annual learning disabilities programme is going. Thank you.
Thanks very much. This was raised actually in the patient and carer session, so I have that down on my list of things to pick up with the board in the private session later, what progress they are making with the annual reviews. As I explained in the previous session, 14 different territorial health boards have taken the commitment to our annual reviews and done it in 14 different ways with very, very different, wildly differing costs associated. So I think probably there is an argument for looking at that piece nationally. Again, progress has not been steady across the country either, despite the priority given to it by the central government. The reason that these annual health checks were introduced is because people with learning disabilities have experienced health inequalities and have an average life expectancy of 20 years less than the general population, largely because of preventable illnesses. So having an annual health check and picking up on these illnesses early when they can be treated is really, really important. I can perhaps, and we can pick up on the national statistics where we are as a country in making progress, but I know that as a country we've not made the progress that we would want to, and I suspect the situation is exactly the same here in Shetland.
Thank you. I'll pass on to Brian to take the second part of that question.
So just before I pass on to Tony specifically about the health checks, I think just looking strategically just where we are, we've been aware for quite a few number of years that data that comes out that we're twice the national average for neurodivergence and learning disability. And I suppose, in a way, as a health board, we've been looking at how we resource that need moving forward and do some of that tackling inequalities piece, particularly around about health inequalities. So we have recruited to a consultant learning disability nurse who's been working right across the life course for children and adults moving forward. But we were very much aware that one person couldn't solve the world. So we've managed to get additional resourcing to go out, and we've just in the process of recruiting another learning disability nurse to come in. Now, that specialty is a little bit like hen's teeth. So we were very lucky to get a nurse consultant coming in at the offset, and then we've had to go out and recruit a number of times to try and get an additionality in the nursing speciality there. But we're hoping that we've been successful on the fourth time of going out. But again, it's maybe not at the level we had anticipated in our planning. So there will be a little bit of time just while we grow that service just moving forward. I think also aware that we can influence the health outcomes, but we also need to influence the other outcomes around about realising full potential, allowing people to live to their fullest potential as well. And I think that's where we've been doing a lot of work with the Integration Joint Board, just around about how we can work to realise better education, better opportunities, better accommodation, better housing, and allow people to realise their fullest potential living in Shetland, and try and tackle that inequality as a whole system rather than just the health as well. But I know we've got a place to play in both of those. And I suppose the last slide that Gary put up round about building healthier communities and our part as a partner and how we influence that for every person living in Shetland, that's very much the holistic part we also have to work hard at as well. I'll just pass on to Tony specifically about the health assessments.
Thanks, Brian, and thanks, Jane, for the question as well. I think it's something that we have been working on. It feels like it has taken longer than we ever expected, but the level of complexity of putting these health checks in place has been really challenging for us as a system. I think what we've really recognised is making sure we've got good sight of who needs access to this and how we can provide good access. But there are colleagues working at an operational team level on this just now, and building on from the work from the primary care phased investment programme. And Gary had in his slides about the long-term condition review checks that have went from 34% overdue to it's actually 14% as of Monday. And proof of that 18% we've had in the slides is some of the methodology we'll build into this. So internally we're looking to develop that learning disability register to make sure that people who are eligible get offered, and they get offered at least every year, and we have good sight and visibility around how we're then performing against providing that learning disability outcome. And it goes with some work we're doing around the Shetland Health Intelligence platform, which also is focused on severe enduring mental illness, because we recognise there's a real overlap between both of these populations, and making sure we use that methodology as broadly as possible for the people who have most benefit. It will take us time though. It's really difficult work, but it's really important work, and we're not going to miss it. We maybe just need to share a wee bit more clearly where we are with delivering on it.
Thanks very much. I don't know where the mic's gone. I think this gentleman here was next.
Thank you. 1, 2. Good afternoon, Minister. I think you know my familiar face from before, Councillor Hallison Duncan, representing the Shetland South Mainland, and among my portfolios within the Council, I'm also the chair of the Safety and Resilience Board. It's the same question that I'm going to put to you again, Shetland Dogs Against Drugs. Funding is becoming more and more difficult all the time, and the lead gentleman who deals with that is, instead of getting out with the dogs and doing the work that's necessary here in Shetland, he's finding, sitting at this desk, trying to find more and more funding. The situation here in Shetland is serious, and it's essential that we must have that dogs for the future. The police here is doing an outstanding and excellent job, and God bless them for that. We've had an increased number of deaths related to illicit substances in Shetland. Very unfortunate. We don't want to see that happen here. So my question is very clear to you. Is there any opportunity of further funding available from the Scottish Government, for example, from the proceeds of crime? Because it's driven here by affluence, not deprivation. And our workforce here in Shetland we can't find enough people to do the jobs that sit vacant, and the unemployment rate is possibly the lowest in Scotland. I will be very interested to hear what you have to tell us again, and I would like to pay a big thanks to you in the past for your support, and also to Ms. Beatrice Wishart, our Liberal Democrat member who has fought this battle bravely in the Scottish Parliament. Thank you.
Thanks very much for that. Certainly that issue has been raised with me since I've come to Shetland again this time, and I have I suspect it is more likely, if there is any funding available from government, that it would be more likely to come from the justice portfolio than from the health portfolio. But that doesn't mean that there would be funding available. I'm going to have to go away and look at that question. From a health perspective, we look at the issue of drug misuse and substance use as a health problem rather than a justice policing challenge, and there are lots of good reasons why we are doing that. We are facing a rise in drugs deaths, not just here in Shetland, and again I've heard about that since I've arrived on island yesterday, but also all over Scotland for a whole lot of complex reasons. We are seeing a very unregulated market with a very high level of contamination, which means that people, when they are buying drugs, are not getting what they think they are buying, and very often it is fatal to take these drugs, so they're contaminated with nicotines, very strong opioids. As a system, so all over Scotland, everyone is trying to respond to that situation. It's actually not just a Scottish problem, it's a UK problem, and it's a worldwide problem. So we're going to have to be a bit agile in how we deal with drugs particularly. I take on board your point around wealth in Shetland and lack of unemployment, and we face many similar issues in the Highlands, in the area that I represent. So there are different challenges in different areas, but one of the really important parts of the work of reducing the number of drugs deaths is getting upstream and preventing the number of people who are taking drugs. And we have a lot of work going on in that space, trying to ensure that children are not growing up in poverty and don't suffer the pernicious impact of a childhood in poverty for the rest of their lives. So it's a complex issue. It requires us to work on lots of different streams. Whether the spend on the drugs dogs is something that should be supported by national funding or not, or whether that's a peculiarly local issue that ought to have local funding, I'm not 100% sure. The other issue, and I think all third sector organisations would recognise that amount of effort that goes into just surviving, so just keeping the organisation going, and there's largely too much effort going into that survival and not enough effort going into providing services. And we are trying, again in central government, we recognise that. We're trying to give 2-year funding, 3-year funding. We're trying to encourage local authority and NHS to do that as well. But we're just everybody is in such a difficult financial situation, and there is no getting away from the difficult financial situation that everyone is in. That means that short-term funding is much more common than longer-term commitments, and that makes it difficult for nearly everyone. So what I would say is keep working with the local community situation, so the local drug and alcohol partnership. I will look into the national issues, but I'm not going to make any promises here. I suspect there isn't any funding, but I'll go away and look at that and see what we can come back with to you.
Thank you. I really don't have much to add to that, but I would like to pay tribute to our own Wendy Henderson and Amanda Pearson and those teams and the mental health team that do a tremendous amount of work locally around this. And I think it's just the fact that those people and that team work so well with one another and with people that things aren't worse here in Shetland. And I don't think it's just the problem of wealth in Shetland. I think there is a poverty aspect to it in Shetland as well. Thank you.
Just as someone that sits on the Alcohol and Drugs Partnership, it's just to say, I think what you've brought up, Councillor Duncan, is one aspect of the detection, but I think what the Minister said round about it being a public health kind of ask of us as part of that partnership, I think that's probably where we're going to get most bang for our buck is round about how we tackle that inequality. Again, it's a bit like the learning disability community, it's how we realise the fullest potential in people. I'm really aware from providing substance recovery and support services that there is a stigma that lies around some of our population who are trying to realise that potential, and how we move forward on that as a Shetland PLC, I think, is part of that as well. It really is about how we get behind that, tackling the inequalities piece, how we destigmatise a lot of what people are on their journey through what is a traumatic time, but often follows trauma as well. So where we are trying to realise some of that is listening to the lived experience, and it's great to see some of that voice here today, and also some of the conversation that the Minister's had earlier on with some of our population and our community around about what matters to them, and I think listening to that is really important as well. And I think we're probably in a different place. We're just about to look at our strategy moving forward. We're doing a needs assessment at the moment as well, and I think that will all play into what is the way forward to support our community be a bit better in an area that we know is having an adverse effect for our community.
Thanks very much. Do we have any other questions?
Thank you. I'm Sandra Lawrenson and I chair Viking Genes Shetland. We are supporting Viking Genes at the University of Edinburgh, and previously over 3,000 Shetlanders have had genetic screening, and a couple of years ago the project was able to return results to those people where they had a genetic variant that was putting them at risk of specific diseases. So far, it's only the diseases that are treatable that are conveyed to them, and I really want to thank NHS Shetland and their NHS Grampian colleagues for providing the pathway to care for those people. We've got a number of people now with specific 2 different heart conditions that are able to get medication. Others are just having increased screening for things like prostate cancer, and the BRCA2 cancer gene is doing ovarian and breast cancer in women and prostate cancer in men. It's quite prevalent here in Shetland, and already we've got good volunteer stories from people who found that they've actually developed a cancer that they didn't know they had until they were able to go onto the pathway and find very early stage, get the preventative treatment and a good bill of health. So based on that, there's a demand for more screening. We've set ourselves the objective to raise £1 million to provide free screening for 5,000 Shetlanders, with the aim to catch more people on the preventative medicine path. And Professor Wilson at the University of Edinburgh is quite keen to move on to more genetic variants. Perhaps some of them are more challenging, but there are opportunities there. And we'd really like this Shetland project to be the exemplar for the rest of Scotland to be able to pick up on this as a preventative measure. But we've got great support here from the NHS teams here in Shetland. And as I've mentioned, NHS Grampian. In one particular strand of people who were contacted, one family has found another 7 cases picked up through NHS screening from the one Viking Genes screen. So it multiplies across families, and we're quite keen to keep our people safe from these particular variants that are common here in Shetland. Thank you.
Gosh, that's phenomenal to hear about. That's real proper cutting edge medicine for people in Shetland, and it's just brilliant to hear about the plans to increase genetic testing and to use that genetic testing with purpose to improve the health of the population. Our understanding, I'm a health professional by background, and I think when I first started working in mental health way back in the 1990s, I stumbled upon, I happened to live in Inverness right next to the global highest concentration of Huntington's chorea. So the Black Isle has the highest number of people with Huntington's chorea in the world. That's a genetic condition that they had only just unravelled the genetic test for it, and they were able to test and identify whether it was a spontaneous mutation or whether it was inherited. It was in the very early days of genetic testing, and being able to test for that has completely transformed the lives of people with Huntington's chorea. Unfortunately, there's no treatment for that, but it has helped them to understand their genetic risk and to make life decisions accordingly. But it's phenomenal, the improvement that has gone on in genetics, and it will only grow. There's a couple of areas that we were very excited, well, I'm a pharmacist, I was very excited about a couple of areas in the programme for government. So genetic testing that is being routinely introduced in NHS Scotland for two areas. One is testing babies, newborn babies, for a genetic mutation which makes them sensitive to a side effect of antibiotics that might be used, which might cause permanent deafness. So by testing all these babies, we prevent a huge level of deafness and disability, lifelong disability that might occur if those babies were getting, and it used to be that you had to do a bacterial test and grow the bacteria, and it took days to see whether you could treat the condition with a different antibiotic. Now we do a bedside genetic test of all these babies and can avoid ototoxicity completely. The other one is a very, very common used antiplatelet drug, which doesn't convert to its active form if in a certain genetic mutation, and we can test people and prevent strokes by giving them the right antiplatelet. So there's huge significance coming from all the genetic testing that's going on, and it's really exciting to hear that you're looking at things in the population here to make a difference. And as you say, to make an actual difference, tangible difference to the health of the people here. It's great.
Thanks, Minister, and thank you, Sandra, for the question. I think it's really tremendous. I came here and listened to Professor Wilson a couple of months ago when he was up giving his presentation, and I think it's just fantastic how, from the work that he's already done, then he knows that certain diseases are more prevalent in some areas of Shetland, and how he's worked that out. And I think senior NHS Shetland staff have already met with Professor Wilson. Brian and myself had a meeting with him, and I think the prospects for this are really, really exciting. I mean, we've already heard just now about some people who have been able to detect disease in the early stages, or in some cases even know that they're at risk from a disease before they actually become ill from it. It is just fantastic. I think the work and the potential of it, I think, is huge. If we can catch people before they become ill, rather than having to deal with people who are having to tell that they've got, for example, a stage 4 cancer, I think it's just phenomenal. I think the outcomes will be better for patients, and I think it'll be much better for NHS Shetland as well if we can intervene earlier to stop people becoming unwell. Do you want to add anything, Brian?
Just it's really timely as well. Government have just released, service reform frameworks and things like that as well, which is really looking at shifting care into the community as well as looking at that prevention kind of aspect, and this does both. So it really does sort of tick those boxes, particularly around about potential illnesses that will have to be cared for in Shetland. If we can do that preventative piece around about those that are specific to Shetland as well, when we come to look at what that looks like in 10, 20 years' time from a service provision kind of perspective, it could really reform what we're doing around about care for our community, and especially in that prevention realm as well. So it is quite timely, and I suppose it's a good sort of nudge for us maybe to catch up with Professor Wilson again, just to say this is how the strategies come from, the policies come from government, and how do we sort of collaborate a wee bit more, maybe just around about some of those higher outcomes as well.
Have we any more questions? There's one right at the back.
Thank you. Can you tell me if there's anything currently happening to the dental service to improve it?
I'll just hand straight.
Yeah, so we are obviously really aware of the dental access problem that's happening at the minute. Actually, not just in Shetland, but there are some other areas in Scotland as well that are going through a lot of the problems we are here, and maybe a bit of a common denominator in a lot of them is the reality that we have. So that influences the people we can get up to come and work for us, as well as also encouraging dental bodies, corporate or independent practices to come up and set up a high street NHS practice as well. So I suppose that's where our work is focused at the moment, is around about enticing the workforce to come up and provide dental care in Shetland. So we are engaged with the education services for the NHS, and we're looking at training a vocational trainee in dentistry from September moving forward. So we're starting at that younger end of the workforce to try and entice people to come up and see the worth of working in Shetland. We've also been very heavily engaged with Promote Shetland and told a number of stories about dentists who have come to work in Shetland to get that out when we're advertising and when we're out for recruitment. So we're doing that at the moment as well. We've also engaged with our local independent practice as well, and we are working with them to see if we can grow the independent sector to improve that access as well. So there's a lot of work that's happening locally. We're also linked into the national work that's happening at the minute with dentistry and to improve access, and part of that is around about playing into that workforce piece, influence some of the policy around about what people can do as a dental professionals and how they can work in different ways moving forward. And the other one is tackling that reality and how we get workforce locally in rural areas to help with that access problem. And things that we're looking at is things like allowances, or some of the learning that we've had off primary care and our GP colleagues, particularly around about the success we've had in Shetland with Rediscover the Joy, which is allowing GPs to cycle through rural areas to provide care, maybe for 2, 3, 4 weeks at a time, and helping some of the workforce issues around about that. So we're definitely looking at how we can learn off other areas of medicine and service provision, but it will take a little bit of time. But I think we're on a better path than we have been in the last 2 or 3 years around about dental access, and I think a lot of that is just some of these pieces in the jigsaw are just starting to fall into place.
Yeah. Thanks, Brian. I should say as well that we're quite active, NHS Shetland's quite active in social media with our recruitment, LinkedIn, Facebook. I can't remember all of the different routes, but if folk in the community would share those posts, you never know, your share might be the one that brings us a dentist or a GP or another professional that we're needing to come and work here in Shetland. Thank you.
Thanks, and I know my colleague Jenny Minto is working hard at national level to try and unlock some of the barriers that there are for dentists. Particularly, we know we have a population of dentists who have come from other places, trained in other places, who would like to work here, some of the barriers that are presented to them in being able to join the regulated workforce here in the UK. There's also golden handshakes and things, enticements for people in rural areas. We are undoubtedly facing a really challenging situation. There's a number of factors that came together. The pandemic year, so the years of the pandemic, meaning that a whole year of dentists didn't qualify. They had to repeat the year. They couldn't train during the pandemic. And then Brexit occurring at the same time. We were very heavily reliant on the European workforce in Scotland, particularly in the rural areas. And Brexit has meant that we just do not have as many dentists as we had before. So we're looking at dental therapy. UHI has a good course in dental therapy, but dental therapists at the moment have to work under supervision of a dentist. So again, every possible strand that we can look at and see if we can unlock those barriers, we are trying to do so, because it's a challenge here in Shetland. It is a challenge all over, largely rural Scotland, but some parts of urban Scotland too. Any other questions? Yep.
Hi, I'm Jen Roberts. I work at the Gilbert Bain Hospital. I'm an occupational therapist. Just want to touch on when you mentioned the rise in the ADHD assessments, and is there anything that's going to be put in place to help reduce that demand or tackle the demand?
So certainly there's a global rise in requests for assessment. So there is undoubtedly more people coming forward for diagnosis all over the world, and that is causing a particular challenge here in Scotland, because our services are unable to cope with the increase in demand, and it's causing a strain all over Scotland. I think I'll hand over to you for the situation in Shetland, where you seem to have identified a higher rate. There's a lot of debate around whether there is a higher rate of neurodivergence in Scotland or not, whether it's higher than it used to be, or whether there's just the stigma has fallen away, and people are actually coming forward for diagnosis, and whether the diagnosis is being made, whereas in the past it would not have been. But there may well also underlying be an increase in prevalence.
Thank you. I'm just going to pass over to Tony McDavid to take that.
Thanks for the question. I think it's something we're dealing with just now. We're very aware of the number of people who are now expecting to have a diagnosis and then a treatment pathway available to them. And that's based on a service that was never that size to provide that level of care and to provide it to that size of population. So there's a lot of work we're doing internally, because we have had some success in the past around having a good, effective assessment process, but there is still a treatment pathway that needs to mature a wee bit in future. I think what we're all getting to grips with as well is that this is quite a mature ask for the population, and what does that look like then in a service going forward? How do we put that together in a really shared way, that it's not just our specialist services that need to be available for people, that this is a common presentation across the population. What we do understand though is that people who have comorbid conditions, so that would be you have suspected ADHD plus something else like a severe enduring mental illness or a substance misuse indication, we are making sure that there is availability of assessment and treatment for those individuals from the specialist services. So one of the things we have to do where there's limited capacity is really think about how we give it to the people with the highest need, and that's something that we're really focused on internally within the partnership and within the mental health team. There's still lots of work to do, and there's only a limited amount of resource to do that work within, but we are planning to have a conversation tomorrow at our joint governance group that focuses on neurodevelopmental pathways, and that's across the spectrum of age, so starting at childhood and into adulthood, and how we would transition between all the people that would need to support an individual with these functional impairments that may come from a condition like ADHD or a neurodevelopmental disorder as well. So I keep coming back to maybe it's complex, it's all complex, but this is a new burden in demand, and we're really keen that we make sure there is the right support for the people who need it most.
Thanks, Tony. I should pay tribute to Tony. Tony is the curator and keeper of our Shetland Health Intelligence platform, and that really is an excellent piece of work. I won't go into all the detail here. In fact, I couldn't go into all the detail here, but by all means go and Google it and look it up and see what it has to offer. But it really does help us when it comes to ensuring that our services deliver for the community. Thank you.
Thanks very much. Do we have any other questions? No? No. So thanks very much, everyone. I hope everyone has found it interesting and worthwhile. Many thanks to everyone who's attended, to the board's leadership team, and everyone who's been involved in organising today's event. As I said earlier, I'm going to summarise all the learnings and key points from the engagements that we've had today in a letter in the coming weeks, and that will be published on the board's website, so you'll be able to see the ministerial letter relating to annual review there. So thank you very much, everyone, for coming along and for contributing and participating. Thank you.